in progress. Good morning. Did we start yet?
Hello, hello, hello. Welcome back, everyone. And I hope every one of you is doing good. Okay. All right. So today we are going to start the pathology, cardiac pathology. Anybody have any question? Any question? Anybody have? No? Oh, okay. That's good. Okay. Let's start the pathology. So we start the pathology with the congenital heart diseases. So congenital heart diseases, first we will discuss those diseases which leads to right to left shunting. Right to left shunting. So it means the blood is actually going from the right side of the heart to the left side of the heart. Okay, right to left shunting. So suppose the right to left shunting means you are mixing the deoxygenated blood with the oxygenated blood, because in the right side of the heart we have the deoxygenated blood. Suppose this is my right side, this is my right side, and this is my left side. Okay, so in the right side, my suppose my car oxygen partial pressure, I would say partial pressure of oxygen is 40, where I would say oxygen partial pressure is 40 or SaO2 is 40. Simply, I will say saturation is 40. The oxygen saturation is actually 40% on the right side. And on the left side, my oxygen saturation is 96%. So what happens? The blood is going from the right side to the left side. So when the 40% blood mixes with the 96% blood, what will happen? It will drop the saturation. So your saturation will drop to 70%. So it means 70% saturated blood will be going to the systemic circulation to your aorta. So what will be the presentation of the baby, or what will be the presentation of the newborn? The newborn is going
Sinus.
very good. So newborn is going to be blue. You will see blue babies at the birth, or simply you will say early cyanosis. So early cyanosis means patient is having what? Patient is having right to left shunting. So today we are going to discuss these right to left shunting diseases. What are the diseases which can actually lead to right to left shunting? So before jumping into these diseases, you know, these right to left shunting needs to be treated very urgently, or they should be treated emergent in an emergency way, because if it is not treated, the patient might die. Patient might die with a complication. So let's discuss the right shunting. So we have the six different types of the right to left shunting. Now, these three types will involve your aorta. Three types involves your aorta, and the three types are within the heart. So these three types, which I am going to discuss now, they lead to early cyanosis by birth, and they are actually natural defects. They are actually the natural defects. They are actually present. Whereas in the other three disorder, we artificially create right to left shunts. So I will discuss that disorder, and you will get to know more. So first disorder I'm going to discuss is called persistent truncus arteriosus, and I have already discussed these disorders with you guys when we were doing the embryology. Is it persistent
Yes.
truncus arteriosus? So persistent truncus arteriosus means your persistent truncus arteriosus means single trunk is going out of the heart. Simply single trunk is going out of right ventricle and the left ventricle. That is called persistent truncus arteriosus. It means your truncus arteriosus is not separated into your aorta and the pulmonary trunk. And I discussed with you, truncus arteriosus was a part of the heart tube which was giving rise to your pulmonary trunk in the aorta. So it was separated normally by your aorticopulmonary septum. So what will be the cause of persistent truncus arteriosus? Failure of aorticopulmonary septum to form. Failure of APS septum to form. Failure of APS, aorticopulmonary septum to form. Now, can anybody tell me aorticopulmonary septum is a derivative of what? It's a derivative of what? It's
Endo- Endocardial cushion.
no, no.
Which one?
I say derivative. Very good. It's a neural crest cell.
Neural crescent.
Exactly. It's a
Yeah,
derivative.
but neural crest cell, it migrates to endocardial cushion, correct?
Oh, no, you're wrong. You're wrong. Justify yourself. It's not the right answer. Okay. So right answer is the neural crest cells. Endocardial cushions is something different, which are the blocks of the mesodrum. They are not coming from the neural crest cells. Okay. Mesodrum means endocardial cushions. Okay. So that's actually called your persistent truncus arteriosus. All right. So persistent truncus arteriosus is due to the defect in the neural crest cells. Due to the defect in the neural crest cells. Now, persistent truncus arteriosus is always associated with the ventricular septal defect. It's always associated with the VSD. And why it is associated with VSD? Because the membranous portion of the ventricular septal defect, membranous portion of the ventricular septum is what? Membranous portion is actually coming from your APS, aorticopulmonary septum. So this is a region it's always associated with the ventricular septal defect. Now the blood mixes, the blood from the left ventricle will mix with the blood from the right ventricle at the truncus arteriosus. So the baby is going to present as early cyanosis. All right. So that's all about your persistent truncus arteriosus. Now, after the persistent truncus arteriosus, we have another disorder that is called transposition of the great vessels. Transposition of great vessels means the aorta arises from the right ventricle and the pulmonary trunk arises from the left ventricle. Okay. Transposition of great vessels. So it's actually opposite. You see, aorta is coming from where? Aorta is coming from right ventricle. Aorta comes from right ventricle. And the pulmonary trunk is coming from your left ventricle. Pulmonary artery coming from the left ventricle. Okay. So this is opposite in the other way. It's completely opposite. So what is the cause of this transposition of great vessels? The cause of
Hy-
trans Yes.
hyperglycemia toxic to the neural crest. Right?
No. That's a risk.
Glucose, it will be toxic to neural crest, correct?
Uh,
Mother of hyperglycemia, correct?
no, that's a risk factor. I'm asking the cause. What's the cause of this? Okay. Risk factor. Hyperglycemia is a risk factor. The cause of your transposition of great vessel is what? Linear development of aorticopulmonary septum. When you get linear development, you see, you guys know that aorticopulmonary septum is normally it's a what structure? Aorticopulmonary septum. Normally it's actually spiral
It's
shape.
a
Spiral shape. If it is not
spiral.
spiral, if it is not a spiral, that will lead to your transposition of great vessels. Okay, linear development of APS. Now, my friend, you were actually telling me the hyperglycemia. Yes, you are right. You're right. But hyperglycemia is a risk factor. Hyperglycemia, so infant of diabetic mother. This transposition of great vessel is seen in infant of diabetic mother because in infant of diabetic mother, you will have the increased blood glucose in the babies or in the fetus. So when you have the increased blood glucose, the glucose is very toxic to the neural crest cells. Is very toxic to the neural crystals. Yes, exactly. So glucose will interfere with the function of the neural crest cells. And when your function of neural crest cell is impaired, it will lead to the linear development of aorticopulmonary septum. So you are going to get what? Transposition of great vessels. Now, this transposition of great vessel is what? It's not compatible. It's not, who's this? Who's this? Okay. Transposition of great vessels is what? Transposition of great vessel is not compatible with the life. It's not compatible with the life. So why it's not compatible with the life? Because you are sending the right ventricular blood to the aorta and the left ventricular blood to the pulmonary trunk. So how will you treat this transposition of great vessels? It's not compatible with the life. So you have to create a shunt. You have to create a shunt at some point to allow the mixing of the blood. So you will create the shunt. Either you are going to create the shunt at what level? You will open the PDA, pedal ductus arteriosus. And when you open the pedal ductus arteriosus, what will happen? The blood from the pulmonary trunk will go to the aorta and then it will go to the systemic circulation. So in this way, it will be compatible with the life. Otherwise, it is not compatible with the life. So you can mix the blood at the level of the truncus arteriosus, or you can mix the blood at the level of ventricular septal defect. You can create the artificial VSD. When you create the artificial VSD, the blood can actually mix at the level of ventricles, okay, or you are going to open the peded foramen ovale. So you have to open these shunts to make the transposition of great vessels compatible with the life. Okay. So that's all about without surgical intervention. If I don't create these shunts, the babies will die. Babies are going to die within a month or within the 2 month. Okay. So this is actually the treatment of your transposition of the great vessels. All right. So another disorder, which is also the disorder of outflow tract or truncus arteriosus, is called your tetralogy of Fallot, which is a third disorder that leads to your right to left shunting. Okay. And that right to left shunting is present naturally. It's present naturally, it is not created. So in these three disorders, right to left shunting is present naturally. We are not artificially doing the right to left shunting. So tetralogy of Fallot. So tetralogy of Fallot means four symptoms you will get. Tetralogy of Fallot means four outcomes are there. So first we will discuss what is the cause of tetralogy of Fallot. The cause of tetralogy of Fallot is a deviation of aorticopulmonary septum towards the pulmonary trunk. Towards the pulmonary trunk. So here I would love to draw the picture here. Suppose this red structure is my truncus arteriosus. So red structure is truncus arteriosus. And normally this truncus arteriosus, I'm again drawing this. I already discussed this with you guys in the embryology, but I see new faces here. So let me discuss that. Okay. So normally aorticopulmonary septum is in the middle, like a spiral structure is in the middle. So when it is in the middle, so this is my pulmonary trunk area. This is my pulmonary trunk. And this is my aorta. So when it is in the middle, you have the 50% lumen of the pulmonary trunk. Pulmonary trunk is 50% and 50% is the aorta. Is it? So it's normally in the middle. But what happens if your aorticopulmonary septum is displaced more towards the pulmonary trunk? So instead of being here, the aorticopulmonary septum goes to your blue color, which is your pathology. So this is the pathologic location. So this is blue one is my pathology, which happens in your tetralogy of Fallot. So this is your APS, which is deviated more towards your pulmonary trunk. It's not in the middle. So what will happen to my pulmonary artery lumen? My pulmonary artery lumen will drop to 20%. Instead of 50%, it become what? It become 20%. Is it? So pulmonary artery lumen will become 20%. And your aorta will become what? 80%. So this is what happening in the tetralogy of Fallot. So tetralogy of Fallot is due to the deviation of APS towards your pulmonary trunk, which will reduce the lumen of pulmonary artery and increase the lumen of the aorta. So can anybody tell me what is the cause of this? Why the aorticopulmonary septum is deviated more towards the tetralogy of Fallot? In what disorder? I mean to ask, in what disorder you will see the tetralogy of Fallot? I mean to ask association. Yep.
Down syndrome.
Down syndrome.
No. Down syndrome is all about VSD and AST, which we are.
George.
DiGeorge syndrome.
Very good. MS. DiGeorge.
That's yours.
DiGeorge. So DiGeorge syndrome is because DiGeorge syndrome will actually is a
That's
disorder
four,
of
three and four.
third and the pharyngeal pouches or cleft or arches. It's a disorder of third and the fourth
Pouch.
pouches. Very good.
Pouch.
Yes, exactly. It's a pouch one. So this is called the DiGeorge syndrome. All right. So now in the tetralogy of Fallot, you are getting four things. So you just start with the what? First symptom is actually what? Pulmonary stenosis. If you remember pulmonary stenosis, everything is a cup of tea for you. So first you get pulmonary stenosis. Okay. Now, because of pulmonary stenosis, what will happen to your right ventricle? Now everything.
Hypertrophy.
Yeah, everything is a consequences of pulmonary stenosis. So second symptom, you are going to get right ventricular hypertrophy. Right ventricular hypertrophy. Okay. What will be your third symptom you are going to get? Third symptom here you are going to get is actually what? This is a disorder of aorticopulmonary septum. So if you get disorder of aorticopulmonary septum, it means you will also get the ventricular septal defect as well. So you get the VSD as well. Now this time, very important to know, normally your VST is what? Left to right shunt. But in the tetralogy of Fallot, your VST can be bidirectional. Most of the time, the VST is right to left. That depending upon the pressure gradient. So in the tetralogy of Fallot, the pressure in the right ventricle is so high. And why it is so high? Because of pulmonary stenosis. So if the pressure in the right ventricle is so high, what will happen? It will allow the blood to go from your right ventricle to left ventricle. So this is called right to left shunting happening in case of your tetralogy of Fallot. So in the tetralogy of Fallot, right to left shunting is due to the ventricular septal defect, which will allow the blood to go from right ventricle to the left ventricle. Now, third, what is the fourth finding you are going to get? You are going to get the overriding of the aorta. Overriding of the aorta means aorta is going above the pulmonary trunk. Why it is actually going above the pulmonary trunk? Because of the increased lumen. Increased lumen, you get the aorta overriding of the aorta. Okay, so these are the four things which you will get in the tetralogy of Fallot. So what will be the symptoms of the patients with the tetralogy of Fallot? So patient with the tetralogy of Fallot will have what? Tet spells, and these tet spells depend upon the pressure in the pulmonary artery. When you increase the pressure in the pulmonary artery, the patient will get the tet spells. What does mean by the tet spells? Tet spells means the baby becomes cyanotic during the episodes. That will be episodic tet spells. Okay, so tet spells are actually there, and these you will see the tet spells when the pressure in the pulmonary artery increases. Tet spells. Okay, so under what situation the pressure in the pulmonary artery will increase? When the baby is breastfeeding. When the baby is breastfeeding or crying, the mother will say that my baby turns blue when he is breastfeeding or when he is crying. So during breastfeeding, or when the baby is crying. When the baby is crying or when the baby is breastfeeding, the pressure in the pulmonary artery increases. Is it? That leads to what? Increased pressure, increase pulmonary vascular resistance. So if you have the increased pulmonary vascular resistance, where will the blood go from ventricular septal defect? That will lead to the shunting of the blood from right ventricle to left ventricle. Is it? And when you get the blood going to right ventricle to from right ventricle to left ventricle, it will go to the aorta. And the aorta will have what? Deoxygenated blood now. And that deoxygenated blood will lead to cyanosis. So this is the reason of the TED spells. Very simple TED spells are there. Now the mother will say that my baby always try to go into the squatting. He always loves to be in the squatting position. Why the baby wants to go into the squatting position? Because squatting will reduce the right to left shunting. So baby's posture will be what? Baby will always try to be in the squatting position. Because when I'm in the squatting position, what happens to my pressure in the aorta? Pressure in the aorta will increase. Is it? That increases pressure in the aorta. And when the pressure in the aorta increases, what will happen to the right ventricular pressure, your left ventricular pressure? It will increase. Is it? And when the pressure in the left ventricle increases, what will happen to the shunt? The shunt will go from where to where? It will go from the left ventricle, it will go from left ventricle to your right ventricle. And that is a good thing. That is a good thing. You want to send the more blood to the lungs for oxygenation. So that will be blood will go from left ventricle to right ventricle. So no cyanosis seen. No cyanosis during squatting. So squatting is going to improve the symptoms of the tetralogy of Fallot patients, whereas your breastfeeding will actually make the symptoms worse. So that's actually your tetralogy of Fallot for you. Now, if I do, so any baby present with these symptoms, what will be your first investigation of the choice? Uh-huh. What will you do as a physician? As a physician,
Chest X-ray. Chest X-ray.
Auscultate.
very good, excellent. So what is chest X-ray going to show me? Chest X-ray. What is very good?
Because they have this boat-shaped heart, like because
Very
of
good.
this.
Very good iPhone. Excellent. Very good. So that they have the boot-shaped heart. Boot-shaped. Boot-shaped heart. Okay. So they will have what? Boot-shaped heart. That's because of the right ventricular hypertrophy. They will have what? Boot-shaped heart. All right. So can anybody tell me the prognosis of the tetralogy of Fallot depends on what factor? I mean to say survival. Survival of the patient depends upon the what factor? The survival depends upon the degree of the pulmonary artery stenosis. If you have the more stenosis of pulmonary artery, it means baby's survival will be less. Baby's survival will be less. So very important to know survival. It's a most important prognostic factor. What's the most important prognostic factor? Pulmonary artery stenosis. So that's all about your tetralogy of Fallot. Now these are all three disorders which are leading the right to left shunt we discussed. Now in other three disorder, we will artificially create the right to left shunting, and you guys will tell me why. Okay. So first we are going to discuss the tricuspid atresia. So tricuspid atresia is there. So first I will discuss tricuspid atresia. What is tricuspid atresia? And then how it leads to your right to left shunting. So tricuspid atresia means complete absence of your tricuspid valve, or failure of the recanalization of tricuspid valve is called tricuspid atresia. Or in simple words, I will say absent tricuspid valve. Absent tricuspid valve. So absent tricuspid valve, it means the blood will not go from. So if your tricuspid valve is absent, it means the blood will not go from right atrium to right ventricle. Is it? The blood will not go. No. And why it doesn't go? Because the tricuspid valve is stenotic. Tricuspid valve is actually absent. So if the blood doesn't go into the right ventricle, so what will happen to the right ventricular size? You will get hypoplasia of right ventricle, because right ventricle will adapt when the blood comes to it. So you get hypoplasia of right ventricle. Okay. All right. Now, you know, now question is this: how tricuspid atresia is right to left shunting? Can anybody tell me? The blood is not going into right ventricle. So how it is going to be, your right to left shunting? So look at this. If your blood doesn't go, so what is happening here? So I'm going to create the artificial right to left shunting. If I don't create the artificial right to left shunting, the babies will die. Babies will die because no blood is going to right ventricle. So it means no blood will go to the lungs, and no blood will go to the left atrium, and no blood in the left ventricle. So what I will do, I will actually artificially create the AST. So when I create the AST, atrial septal defect, artificially create the AST, what will happen? I will shunt the blood from right atrium to left atrium. Okay. I shunt the blood from the right atrium to the left atrium. Now from left atrium, the blood will go to the left ventricle. Now I send the blood to the left ventricle. So from left ventricle, where will I send the blood? I will send directly to the aorta, or I will send it to the right ventricle first?
Right ventricle, because you want it to get oxygenated.
Excellent. Very good. Excellent. So it will go to the right ventricle. And from right ventricle, it will go where? It will go to the lungs. And from the lungs, it will return back again to the left atrium. Okay. It will return back to the left atrium, but because of the AST open, some blood will go to right atrium, but most of the blood will go to the left ventricle. Most of the blood will go to left ventricle because it goes downward. You know, it's very easy to send the blood downward as compared to the on the sides. So most of the blood will go to the left ventricle, and this time the left ventricle will send the blood to the aorta. So this is only compatible when you create the both ASD and the VSD. You have to create the VSD as well, because if you just create the ASD, the blood will only go from right atrium to left atrium, and from left atrium it will go to the left ventricle. But in order to send the blood to right ventricle, you need VSD to be open. Okay, so look at this here. I do what? How it is right to left? I mix the blood of right atrium with the left atrium. Now my question from you is that why the blood is going from right atrium to left atrium? You see AST is open here. AST is open here, but why the blood is going from right atrium to left atrium? Why the blood is not going from left atrium to right atrium? Anyone?
Because the pressure will build up there because there is a stenosis.
Excellent,
But-
excellent, excellent, excellent. Good job. The pressure will be very high in the right atrium, so which will drive the blood to go from right atrium to left atrium, because left atrium does not have a blood. Left atrium does not have a blood, so left atrial pressure will be almost zero. Okay, so this is actually called tricuspid atresia, which we artificially created right to left shunting for the viability of the baby. Now, other disorder in which we will also artificially create the your right to left shunting will be the very interesting disorder that is called total anomalous pulmonary venous return. The name is said total anomalous. Anomalous means abnormal. Total anomalous pulmonary venous return. So what is total anomalous pulmonary venous return means? It's a completely abnormal. So first you have to look at what is happening normally. So normally, what is the normal blood flow? Right atrium. Blood goes from right atrium, it will go through the right ventricle, and from right ventricle, where it will go? It will go to the pulmonary artery. Okay, pulmonary artery. And from pulmonary artery, where will the blood go? From pulmonary artery, it will go to where? It will go to the lungs. And from lungs, the blood will go to the pulmonary vein. And from pulmonary vein, it will go where? It will go to the left atrium. And from left atrium, the blood will go where? To the left ventricle. And from left ventricle, it will go to the aorta. So this is what normally happening. Okay. Now, what is happening in the pathology? Very important to understand what's happening in the pathology. So the blood goes from the right atrium to right ventricle. From right ventricle, it will go to the pulmonary artery. Okay. And from pulmonary artery, it will go to the lungs. And from lungs, it will go to the pulmonary vein. But here, what happens? Instead of going to the left atrium, it will return back to the right atrium. Pulmonary vein is going to drain the blood into your right atrium. So blood is flowing in the closed circuit. It's a closed circuit. From pulmonary vein, it will go to the right atrium. So it means no blood in the left atrium and the left ventricle. No blood in the no blood in the left atrium and left ventricle, is it? So I have to create the shunt. Otherwise the patient will die. Because there will be no blood in the aorta as well, is it? Okay, so what kind of the shunt? Can anybody tell me where I should create the shunt? As a cardiac surgeon, what I will do? As a cardiac surgeon, I have to be very careful. Otherwise, the baby is going to die. Yes, anybody knows the answer? What shunt I will create?
Right to left shunt.
Very good. At what level? At the atria, at the level of atria, at the level of ventricle, or at the level of the aorta?
At the level of atria.
Excellent. At the level of atria, because I have to think about the left atrium as well. So I will create valve. I'm going to create the AST. I'm going to create the AST. So AST will allow what? It will allow the right atrial blood to go to your left atrium. And from left atrium, this will be AST. So I artificially create it. Okay, once I artificially create, the blood will go to the left atrium, and from left atrium it will go to the left ventricle, and from left atrium it will go to the aorta. So this is actually viable with the life only when I create the shunt. If I don't create the shunt, what is going to happen? The baby is going to die because your cardiac output cannot be maintained. Okay, your cardiac output is not going to be maintained. So that's actually very important to understand. All right. So this is actually called total anomalous pulmonary venous rate. And now last disorder which will lead to your right to left shunting, which we artificially created, I would say, that's called Ebstein's anomaly, Ebstein's anomaly. How you guys pronounce this? Ebstein's anomaly. Okay, so we have the Ebstein's anomaly being there. So Ebstein's anomaly is actually what? Is actually the displacement of the tricuspid valve into the right atrium, sorry, right ventricle. Okay. So what happens in the absence anomaly? What's the definition? You get displacement of tricuspid valve into right ventricle. And when I displace the tricuspid valve into right ventricle, it is also called atrialization of the right ventricle. It's also called atrialization. So I'm artificially atrializing the right ventricle. Okay. So the question is this: how it leads to then what's the cause of this? First, let's discuss what's the cause of absence anomaly. Mother using
Lithium.
very good, excellent. Mother using lithium during pregnancy. Lithium during pregnancy or bipolar disorder. Now, question is that how it is actually right to left shunt? How it is right to left shunt? When I get tricuspid atresia, when I get tricuspid valve being displaced with right ventricle, how it is actually? Can anybody tell me how it is actually right to left shunt? Yep. Mm-hmm. It's just displacement of tricuspid. Think. Mm-hmm. Yes. Mm-hmm. So when your tricuspid valve goes down into right ventricle, it will decrease the cavity of right ventricle. Almost your right ventricle will be hypoplastic. So it means there will be reduced blood in the right ventricle, decreased blood in the right ventricle. Okay. So your blood is actually decreased in the right ventricle. So if your blood is decreased in the right ventricle, it means what will happen? There'll be decreased blood in the pulmonary artery. Okay. And similarly, decreased blood will go to the pulmonary vein. So you will have the reduced blood going to the left atrium. Okay. So the decreased blood will be in the left ventricle. So this is not a good thing because there should be more blood in the left ventricle. So what will I do? I'm going to create artificial atrial septal defect. I'm going to create what? Artificial AST, which will allow what? I will create the artificial AST. So AST will be created, and that AST will do what? It will allow the blood to go from right atrium to left atrium. And from left atrium, the blood will go to the left ventricle. So if the blood goes to the left ventricle, what will I do to the left ventricular blood? I will directly send it to the aorta, or I will send it to the right ventricle.
Right ventricle.
No. Think. My right ventricle is actually very small. I cannot send the blood to the right ventricle because it cannot accommodate the blood. If I send the blood to the right ventricle, it will be waste. It will be waste. So I will directly send it to the aorta. And when I send the blood to the aorta, from aorta, I will think that I should send the blood to the lungs. If I don't send the blood to the lungs, who will oxygenate it? So I am going to create the artificial PDA here.
PDA, correct, yes.
That
To
it
go from the
does.
aorta to the pulmonary artery.
Excellent. So PDA should be created, which will allow the blood to go to the pulmonary artery. And once the blood goes to the pulmonary artery, it will go to the lungs. And from lungs, the blood will return back to your left atrium. That will be oxygenated blood. I have to send the oxygenated blood to my brain. I will not send, okay. So that will be oxygenated blood will be there. And that oxygenated blood will go to the left ventricle. From left ventricle, it will go to the aorta. So this is what happens. So you will have to create the artificial AST and the PDA to make it compatible with the life. So that's called the Epstein anomaly, which is actually a right to left shunt. So now we will discuss the disorders from left to right shunts.
So
Did you?
here, sir, so here we are making two shunts in the
Yeah, we are
Epstein
making two
anomaly.
shunts. Yes, very good. We are making two shunts.
Okay.
First, I have to create the shunt at the atria. Then I will create the shunt at the level of aorta. Get it? Anybody have any question?
Yes, thank you.
No worries. Okay, now we discuss the left to right shunts. Two. right. Left to right shunt. So in the left side, I already told you, in the left side, so suppose this is my left side and this is my right side. So what happens in the left side? You see, in the left side, I have the oxygen saturation of 96%. SaO2 is of the 96%. And here my SaO2 is 40%. So I'm mixing the 96% blood with the 40%, is it? So when I mix the 96% blood with a 40% blood, it means the saturation will go up. So this saturation will go to 70%. Is it? So this will not present with the cyanosis. Babies are not going to be cyanotic at the time of the birth. At the time of the birth, they will not be cyanotic because left to right shunt, I'm just mixing the oxygenated blood with the deoxygenated blood. So no cyanosis at birth. No cyanosis at birth. No cyanosis at the birth will be seen, but important thing is that if you don't treat the left to right shunt, the shunt might reverse. Shunt might reverse. Your shunt might go from right to left with the life, with the passage of the life, the shunt might reverse. And once your shunt reverts, it might present as a cyanosis. That will be called Eisenmenger syndrome, which I'm going to discuss with you. Eisenmenger syndrome. So first, I will discuss the three disorders which are actually left to right. Okay, so first disorder I will discuss is called AST, atrial septal defect. So atrial septal defect is actually due to the failure of the formation of your septum primum or septum secundum. So if any of the septum doesn't form, it will lead to the AST. I already discussed with you guys what is septum primum, what is septum secundum in the embryology. Okay. So what is actually atrial septal defect is actually failure of septum primum, failure of septum primum or secundum to form. Secundum to form. And that will lead to the open defect. That will lead to open defect between right and the left atrium. Open defect between left atrium and right atrium. Okay. So that will be your atrial septal defect. And what is the most common type of the AST? That's very important to understand. The most common type of the AST you get is called ostium secundum defect. And if you get the ostium secundum defect, can anybody tell me that will be due to the failure of what septum to form, secundum or primum? Yep. Most common type of the atrial septal defect is called ostium secundum. It's called ostium secundum. And if you are getting ostium secundum type of the AST, it will be due to what? It will be due to the failure of septum primum to form or septum secundum to form. Anyone?
Primum.
No? No? Secundum to form. Septum secundum to form. Because you guys know that ostium secundum is actually what? Ostium secundum is a cavity created because of the necrosis of the septum primum. So once your septum primum form, what will the body do? What will the fetus do? It will lead to necrosis of the septum primum. And once you do necrosis of septum primum, you produce ostium secundum. So to close the ostium secundum, your septum secundum should grow. So it will be due to the failure of septum secundum to form. Very important to understand this. I already discussed that in the embryology. Okay, so that will be the most common type of the AST you will get. Okay, now.
But I'm sorry, doctor, but sometimes the septum primum, the ostium, the necrosis take too long. It makes it bigger. So when the septum secundum comes down, it doesn't cover the whole ostium.
So that's what I'm explaining you. That's what
Okay.
That's what I said. What did I said? I said to you, septum secundum, the defect in the septum secundum will lead to ostium secundum. That's what I said. Okay. Okay. All right. So that will be your AST. All right. All right. Now we're going to discuss the symptoms of the AST, how the AST is going to present. Anyone? Will there be any symptoms from the AST? No symptoms will be seen. AST is asymptomatic. Is it? It's asymptomatic. T is what? Asymptomatic. It's asymptomatic. AST is asymptomatic. But if it is not treated, it will lead to heart failure. It leads to heart failure, and I will prove it how it leads to heart failure. Just keep patience. Okay. So in the AST, if your AST is open, so it's asymptomatic. But what will be the physical examination finding in the AST patients? Can anybody tell me what will be my physical examination finding? If I actually examine the patient, what will I get on the physical examination? Yep.
Murmur.
Murmur. What type of the murmur I will get? Very good. You're right. But what type of the murmur? You're right.
It should be
Systolic ejection.
Systolic ejection murmur.
Systolic ejection murmur. You mean to say flow murmur? You guys mean to say flow murmur? Yes. You guys will get the flow murmur. And what will be the location of this murmur? It will be here in what location? I already discussed with you guys. That's why I'm quizzing you.
Pulmonic area.
Very good. That will be your left second intercostal space. Very good. Pulmonic area. So one will be the murmur. What other finding you will get? What will other physical examination finding? First, you get the flow murmur, and that will be pulmonic area. Very good. What other finding you are going to get?
Fixed splitting of S2.
Fixed splitting to
Excellent. Fixed splitting. Now, can anybody who wants to actually tell the mechanism of fixed splitting? Because new faces are there. They want to actually hear from you guys, because I already discussed with you fixed splitting. Why do we get
It is because of delayed closure of pulmonic valve. Because more blood is going from left atrium to right atrium and right atrium to right ventricle.
Yeah, I mean, delayed closure of the pulmonic valve also happens in the wide splitting. You see, wide splitting, delayed closure is there. But what is fixed splitting? First, define what is fixed splitting.
Similar type of delay during there is no change in inspiration or expiration.
Archana wants to answer. I don't know how to pronounce your name. Sorry if I'm wrong.
Archana, sir. Similar type of delay during both inspiration and expiration.
Exactly. Very good. Excellent. So when you get the similar type of the delay with inspiration and expiration, that's called fixed splitting. So can anybody tell me why I'm getting the delay, same amount of delay during inspiration as well as expiration? What's the reason? Yep.
Because blood is going from left atrium to right atrium during expiration, left atrial pressure is more than
excellent.
right.
Very good. Very good. Excellent. Good job. Very good, Archana. Excellent. So because what happens when you are doing expiration, the pressure in the left atrium is more, so it will drive more blood into the right atrium. So more blood will go to the pulmonary artery during expiration. But with inspiration, the pressure in the right atrium is equals to the pressure in the left atrium. Why? Because with inspiration, the venous return increases to the right atrium. So with inspiration, you don't see delay because of the AST. You see the delay because of the normal physiology. Okay. So AST delay is seen only with the expiration, not with the inspiration. AST has a no effect on the inspiration, it has an effect on the expiration. Okay. So that is called the fixed splitting we get in the fixed wide splitting you are going to get with the atrial septal defect. All right. So that will be the symptoms here. Now, other finding which I will get, if I measure the oxygen saturation, the oxygen saturation will start to rise at the level of right atrium. So at the level of right atrium, the oxygen saturation will start going up. So suppose normally the right atrial oxygen saturation is actually what? It's 40%. It's 40% normal. But what will happen if I mix the 96% blood at the level of right atrium? What will happen to the saturation? The saturation will go to 70%. So same amount of the saturation will be seen in the right ventricle. In the right ventricle, you will also get 70% saturated blood, and the similar amount of the saturation will be seen in the pulmonary artery. Okay, so that is actually saturation. So very important to understand the saturation. That is how we differentiate your atrial septal defect from ventricular septal defect. Okay, so that will be your, all right. So very important to understand your atrial septal defect is different from the padded foramen ovale. Padded foramen ovale is just a small defect within the atrial septum. that is due to the failure of the septum primum to fuse with the septum secundum. It's very smaller defect, and that will always present with the paradoxical emboli. And I discussed with you guys what is actually paradoxical emboli. So AST is most commonly seen in the Down syndrome patient. Down syndrome patients will have the defect in the ostium secundum. That's due to the failure of septum secundum to form. All right, so that was all about your AST. Now we will discuss another disorder that's called ventricular septal defect, VSD. So VSD. So VSD is defined as your defect in the ventricular septum is called VSD, and that VSD is actually the most common type of the VSD you get is called the membranous VSD. Membranous VSD. So membranous VSD is actually failure of the formation of the membranous interventricular septum. Membranous VSD. Okay, and membranous VSD is most commonly due to the neural crest cell defect. When you get neural crest cell defect, it will lead to membranous VSD. Okay, neural crest cell defect, and that's always associated with your pathologies of truncus arteriosus, as I discussed with you, because APS septum is also neural crest cell derivatives. All right, now what is the most common cause of the VSD we get? VSD is most commonly seen in the two disorders. Can anybody tell me what are those two disorders which are associated to the VSD? Yep.
Yes, maternal diabetes mellitus.
Yeah. One is called your Down syndrome. And what's the other disorder which will also lead to your
The
VS?
babies whose mother is diabetic.
No, diabetic is transposition of great vessels.
Fetal alcohol syndrome.
Alcohol.
Excellent. MS, very good. Fetal alcohol syndrome, very good. MS, appreciate it. Fetal alcohol syndrome, because alcohol is very toxic to the neural crest cells as well. Okay, fetal alcohol syndrome. Okay, all right, which have the smooth philtrum, all these facial dysmorphic symptoms. So these are the two associated symptoms of VST. Now, how does the VST present? What are the symptoms of the VST presentation? Will VST be symptomatic or asymptomatic? It will be asymptomatic. It will be asymptomatic, but it may manifest later in the life. It may manifest later in the life with the blue babies. I will discuss with you how it will lead to the cyanosis later on the life. So what will be the physical examination finding in the VST? What type of the murmur I will hear in the VST?
Continuous.
Holosystolic.
Holosystolic, harsh holosystolic. I would say harsh holosystolic murmur. Harsh holosystolic murmur, best heard at the tricuspid area, is it? Holosystolic murmur, best heard at the tricuspid area. Okay, so that will be your VST presentation. Now, this VST murmur will be heard in the larger VST or smaller VST?
Small VSD.
Smaller VSD, very good, because larger will not generate the pressure, is it? Smaller VSD. So smaller VSD will easily resolve by itself, but we have to treat the larger VSD, because if we don't treat the larger VSD, it will increase the blood flow to the pulmonary artery, and when you increase the blood flow to the pulmonary artery, it will lead to Eisenmenger syndrome, which I'm going to discuss. Okay, so that's all about the VSD. Now in the VSD, the oxygen saturation will start to rise at what chamber? At the right ventricle or at the left at the right atrium? Oxygen saturation. So saturation of
Right ventricle.
exactly. It will actually start to go up at the right ventricle because the mixing is taking place at the right atrium. Sorry, right ventricle. So my right ventricular oxygen saturation is going to be 70%. So same will be seen in the pulmonary artery, whereas my right atrial oxygen saturation is going to be what? It will be my 40%. Okay. Why? Because the mixing does not take place at the level of the right atrium. It's taking place at the level of the right ventricle. Okay. So that's all about your VSD. Now we are going to discuss the last disorder, which is also your, I would say, left to right. It's called your PDA, pedal ductus arteriosus, PDA. Now, PDA is actually, you're getting the shunting at the level of the aorta and the pulmonary trunk. So PDA is actually what is due to the failure of the closure of the ductus arteriosus. Failure Can anybody tell me what are the causes of this PDA failure of? I already discussed these topics with you guys. You should be very good.
Prematurity and congenital rubella syndrome.
Very good. Could you please tell me mechanism why prematurity failure of Cloyer of ductus arteriosus?
Because
So number
yeah,
one was you told me the prematurity. Why prematurity? Because your ductus arteriosus start to close after 32 weeks of the gestation. Before
yes.
32 weeks of the gestation, it will not close. So that's prematurity is a number one risk factor. That's a one reason for the prematurity causing PDA. And can anybody tell me what's the other reason? One reason is
Congenital rubella.
no. I say
Prostaglandin.
no, prematurity is a risk factor. So premature risk factor because of two reasons. One reason because ductus arteriosus start to close after 32 weeks, and second reason is that prematurity will increase the risk of ARDS, acute respiratory distress syndrome. So if you get acute respiratory distress syndrome, what will happen to the oxygen level in the babies? So the PaO2 partial pressure of oxygen will drop in the babies. Is it because lungs are not working? So if you don't have oxygen, will the PDA close? PDA will never close if you don't have oxygen. Is it? So because of the decreased oxygen, your PDA will not close. So you get what? Open ductus arteriosus. So these are the two reasons why I'm discussing this, because management is totally dependent upon oxygen. You know, how do we manage the PDA? We give the supplemental oxygen to the babies to close the PDA. Okay. So this will be open ductus arteriosus will be seen, prematurity will be there. Now, second cause is called congenital rubella syndrome. Okay. Congenital rubella syndrome, which will lead to your PDA. Now, PDA, how does a PDA present? What will be the typical presentation of the PDA guy symptoms? Yep. Anybody who wants to take the chance here?
Having machine-like murmur.
Excellent. You get the continuous machine-like murmur. And what's the location of that murmur? Machine-like
Left intraclavicular region.
Very good. Left intraclavicular space, which is the location of a continuous machine-like murmur. Okay, that will be the presentation of your PDA. Okay, and how do you treat the PDA? Anybody who wants to tell? Continuous machine-like murmur will be seen.
We give endomethacin.
We give very good. We give what? Endomethacin to reduce the prostaglandin. Very good. One is exactly this. And second, we will give the supplemental oxygen, because oxygen will close your ductus arteriosus. Okay. So that will be the treatment for the PDA, because if you don't treat the PDA, if you don't treat the PDA, what will happen? Later in the life, the PDA will lead to cyanosis. And what kind of the cyanosis you will get in the PDA? That will be called differential cyanosis. Once you get the reversal of the shunt, I am going to discuss with you guys why you get the reversal of the shunt. So that will lead to differential cyanosis. Differential cyanosis means your upper extremities will appear rate and healthy, whereas the lower extremities will appear cyanotic, because ductus arteriosus is the connection distal to the left subclavian artery. Distal to the left subclavian artery, so you will get the differential cyanosis means blue lower extremities and the upper extremities will appear red. So that will be the complication of the PD if it is not treated. If it is not treated early. Okay. So now I'm going to discuss the reversal of the shunt, that is called Eisenmenger syndrome. Okay, Eisenmenger syndrome is a complication of the untreated left to right shunt. Eisenmenger syndrome, and I'm going to tell you how it's a complication of untreated left to right shunt. Eisenmenger. So Eisenmenger syndrome, as I discussed with you, is a complication of untreated left to right shunt. So suppose if I don't treat, suppose left ventricle sends blood to right ventricle through VSD, and right ventricle will send more blood, increase blood to the pulmonary artery. And when you send more blood to the pulmonary artery, what will the pulmonary artery do? Anyone? What will the pulmonary artery do if I send a lot of the blood in the pulmonary artery? What will the pulmonary artery do?
Smooth muscles hypertrophy.
Excellent. They will adapt. They will adapt because you are putting more burden on them. So that will lead to the hypertrophy of your vascular smooth muscles in the pulmonary artery. Hypertrophy. So you get hypertrophy of smooth muscle cell. And when you get hypertrophy of smooth muscle cells, what will happen to the lumen of the pulmonary artery? It will decrease the lumen of pulmonary artery, is it? Decrease lumen of pulmonary artery. And if you decrease the lumen of pulmonary artery, what will happen to the pressure in the pulmonary artery? The pressure will increase in the pulmonary artery, is it? And when you increase the pressure in the pulmonary artery, what will happen to the pressure in the right ventricle? Yeah. What will happen to the pressure in the
Will
right?
also increase.
Very good. The right ventricular pressure will increase. So it will increase right ventricular pressure. And when you increase the right ventricular pressure, what will happen to the shunt? Because right ventricular pressure is now greater than the left ventricular pressure. So the blood will go from the right ventricle to the left ventricle. Blood will go from right ventricle to the left ventricle, and this will allow the deoxygenated blood to mix with the oxygenated. Because in the right ventricle, I have what, 40% saturation. And in the left ventricle, I have the 96% saturated. So they will mix with each other, and I will get what, 70% saturated blood in the left ventricle. So when I get 70% saturated blood in the left ventricle, the baby or the patient will become cyanosis. So this is called the late cyanosis, and this is a complication of untreated ventricular septal defect, or untreated left to right shunt will always lead to Eisenmenger syndrome. So your Eisenmenger syndrome is characterized by three findings. What will be the three symptoms of the Eisenmenger syndrome? Three symptoms of Eisenmenger syndrome. So first symptom of Eisenmenger syndrome will obviously be late cyanosis. Late cyanosis. Okay. And second symptom of Eisenmenger syndrome, you will get what? Polycythemia. Can anybody tell me why do we get polycythemia in the Eisenmenger syndrome? Polycythemia means increased number of the RBCs. So why do I increase the number of RBCs in the? Very good.
Because of hypoxia, there will be increase in erythropoietin
Very
levels.
good. Very good. Because of reduced oxygen, you get what? Increased EPO release from the kidney. And the EPO will do what? It will stimulate the bone marrow to produce a lot of the RBCs. Okay. So that will be polycythemia. Okay. And the third symptoms of your Eisenmenger syndrome is what? It's called clubbing. Now, clubbing is actually what? Clubbing is a loss of the angle between nail plate and the nail bed. So you get what? Loss of the angle between nail plate and the nail bed. That's secondary to the fibrosis of the nail bed. You get fibrosis of nail bed. And when you get fibrosis of nail bed, what will happen? It will lead to the loss of angle between nail plate and the nail bed. Now you guys must be thinking, why do I get the fibrosis in the Eisenmenger syndrome? Can anybody tell me why do I get the clubbing in the Eisenmenger syndrome?
The same reason is occurred here because of hypoxemia.
What will the hypoxia do? You're right. So when you have the reduced oxygen, what will it do?
There
Vascular
is
and residual
adaptation.
growth factor release.
One by one. Who wants to answer? So when
No,
you have the reduced hypoxia, when you get hypoxia will lead to release of hypoxia inducible factor 2. And that hypoxia inducible factor 2 is a transcription factor. It's a transcription factor which will do what? Which will increase the gene expression of fibroblast growth factor. And when you increase the fibroblast growth factor, it will do what? It will increase the proliferation of fibroblast. And when you get increased proliferation of fibroblast, what will happen? You will get what? Fibrosis of the nail bed. And that is clubbing. You guys know clubbing is always associated with those disorders which cause hypoxia in the body, like your restrictive lung diseases, adenocarcinoma of the lungs. So these are actually your causes of the clubbing, and that's secondary to the hypoxia we get. Okay. So that's all about the Eisenmenger syndrome, and that's because of the untreated left to right shunts. Okay, so that was all about congenital heart diseases. So tomorrow we discuss the hypertension, atherosclerosis, and the coarctation of aorta. All right, anybody have any question? Everything good? All right, any question anybody have? Everything good? Okay. I see you guys tomorrow. Bye bye. Take care. Okay.